thanks everyone for coming this morning. I know time is precious, so we'll kind of get right into it. This is my first time here. Thanks for having me. I know you guys get to pick who shows up. You asked for Dave, but he wasn't available, so you get the next best. My background, I'll throw it out here right now. I am not a clinical person. My background is in healthcare, fire protection from a physical building standpoint. So that's kind of the route we're going to take here. Talk about the physical features in the building that help protect you. But when we get to some of the specifics in the clinical realm, I'm going to rely on you for your expertise, and we can talk through those specifics. So we have all kinds of information about the best practices and things. So if there's something that you do differently or something, please let's talk through it, and we can kind of have an open dialogue that way. All right, but I'll just throw that out there now. When we get into some of the procedural type of conversations, we'll work through that slowly. So like I said, my background is in the hospital, physical building type of thing. So where do we come from when we talk about fire protection? Well, there's kind of three branches here. We have an understanding of the best practices across the country. There are folks on our staff that sit on a number of different technical committees. We have interaction with the AAORN and those types of folks to understand what is going on out there and the best way to protect our patients in this clinical realm. We understand the CMS and the authority having jurisdiction requirements. We help have conversation in that aspect. We sit on NFPA technical committees. We help write the code. We have an understanding for why it's written the way it is, so we can help you comply with those rules. And then the response. After something happens, there's a catastrophic event, something of that nature, we go and have after incident interviews. We talk to the staff. What worked for them in some cases, or what didn't work for them? And we want to kind of bridge that gap there and focus away from those things that didn't work and drive towards the things that work. So that's kind of where we're coming from. And kind of this is why we're doing it. We're protecting the patients, and how we do that kind of funnels down to the conversation today. So what we're going to talk about, we'll talk about surgical fires or surgical evacuations in the news. They're not always fires that force you out of the operating environment, so we'll talk about a few of those examples there. Understanding what happens in your environment here. Talk about your fire procedures specifically and how we will relocate within. We'll talk about prevention, how do we prevent something from happening, and then if something were to occur, how do we put those fires out, and we'll talk suppression. That's when we'll get live, we'll light the table up, or light the bed up, and see what happens there. So we'll get hands-on. Who here has been through one of these surgical fire safety trainings with RPA in the past? Okay, a few of you. Anyone new has not been through one of these with Russell Phillips? Oh, a couple of volunteers, so thank you so much. Be my helpers with it. Like how we did that? All right, so let's get right into it. We'll talk about, give an example here of a hospital that had to evacuate their operating room when there was not a fire.
Kelly, the emergency and operating departments have been turned back over to the hospital, but they're not ready to reopen just yet. The question of how this all happened still lingers. Outside Exeter Hospital, doctors and nurses taking care of their own after a mysterious odor sickened 19 staff members.
All of those folks had very minor issues. They've all been, as far as we know, have all been sent home.
Friday morning, they felt nauseous and dizzy. Operating rooms were evacuated, as well as parts of the emergency department. No patients were physically impacted. 12 staff members were transported to other hospitals. The rest went home on their own.
Obviously, something caused the issue this morning.
While the ED and OR were shut down, the rest of the hospital continued running. Hazmat crews searched affected areas of the building.
We sampled air, we sampled everything normal, filtration, everything in the OR and the ED, and found nothing that would have caused this.
Firefighters say whatever caused the issue is now gone, and that this shouldn't happen again.
So it's not always a fire that forces you out of the environment there. This was an odor. They don't know what caused it, and they don't know how they're going to prevent it. He said it shouldn't happen again, but they don't really know what caused it. So it's not always that immediate, get us out of here because there's a fire and we need to put it out. There can be something else going on. So let's talk through some of the things, some of the challenges that they faced. It happened quickly. People just started getting sick, so they had to quickly kind of regroup and figure out what was going on and get people moving around. They don't know how many people were sick or moved around. They kind of lost count of people. So that was one of the challenges that they faced there. They had active cases. They couldn't get to them. So the people were sick. So they didn't know where to go to or from. In a fire, you kind of know where the fire is, so you know where to stay away from it. In this particular instance, they didn't really know where the source was, so they didn't know if they could move. They didn't know where to move to or from. And then media coverage. You saw the helicopters were out watching everybody outside. They were faced with that kind of challenge of what are we doing with people? What does it look like we're doing to people? Putting them out outside. It was a nice sunny day at the time. You guys here in Nebraska, I'm from Cleveland, so I understand the winter weather. You guys get that same type of weather. Would that be an appropriate place to put them if it's December out?
No.
Probably not. I don't imagine it would be. So that's some of the challenges that you may face when dealing with this particular. What's that? Okay, right. Depends on the patient. So what worked for them? So they had alternate ORs. They had a whole separate site that they could move folks to once they finally figured out what the source was, where the source was coming from that was causing these illnesses. They were able to relocate to those operating spaces and continue the cases. But they had to figure that out first. So it took a lot of communication and figuring things out. They had their incident command system. They actually stood it up for that, figuring out, all right, who is where, who can we relocate, what kind of staff do we have in the building to support us in relocating and standing those other spaces up so we can continue our cases in those spaces. So they had to actually stand all that up to get the communication going and get it through that way. They had community partners. They brought in, obviously the fire department arrived, but they had to get in the utility companies to figure out what was going on. And then once they got them involved, then they really started to figure out the source and get things figured out. But they got them involved quickly because they needed the support from the outside. So that worked well for them. And then the actual downtime for the ORs was somewhat minimal. They got folks involved, they figured out the source and took care of it. So in this type of case, where it was some sort of odor that they didn't really know where it was coming from, they figured it out and solved it. If it's a fire, if there's smoke and there's all kinds of damage to the building, to the physical space, you can't necessarily go right back in there and start operating in that space again. But if we take care of it quickly, we can actually keep the downtime to a minimum and get back to business. But what we're trying to avoid is this type of situation where you get the helicopters outside, figuring out what's going on. This is just, it's a bad mark. No one got injured, no one was hurt, well, aside from the people that were getting ill from the odor. No patients were injured. But is that the headline? That's not the headline. The headline is, oh, there's something going on in the hospital, and now we got all kinds of people outside, and they're not being treated. So understanding that the perception is huge in that case. So this isn't isolated to Exeter Hospital there. It happens all over the place. Boston, there was a sewage leak in the roof, caused the ORs to have to evacuate quickly. Gas leak in Spokane, and there was a chemical spill. So things that are around you, you're doing all you can in the operating space to prevent the fire, prevent things from occurring that you need to relocate. Sometimes things happen. That's why we like to practice this evacuation later on today. We're going to go into those spaces, actually put hands on with your equipment. We could do a practice session here with this hospital bed, or this stretcher here. But that's not your equipment, your space. Each room has a different layout, different equipment in there, so we want to put hands on there. That's why we demonstrate, because it's not always a fire that gets us out of there. It could be something totally out of our control, and we have to relocate due to that. Right? Kind of just driving it home there. So when the fire is the force that gets us out of there, whether it's a fire in the operating space or there's smoke. Maybe there's a piece of equipment that's pushing smoke into our space. Two very different ways to deal with this, right? If we're able to quickly put this fire out, do we have to evacuate? I'd say no way. That patient is much better in that space, right there, with everyone available, than having to relocate just because the fire has been put out. We do want to do some things, we'll talk about the reaction to that, but we don't want immediately need to move people. But if we're in a space like this, where we can't function in there any longer, it's dangerous, we need to seriously consider getting out of there. Okay, so kind of the two different aspects there, we'll talk about the decision making there. So your fire procedures, this 4-letter word we talk about when we talk about fire response. RACE, right? What's that R stand for? Rescue anyone in immediate danger, right? Or in the case of a fire on or near the patient, remove the danger. Let's put the fire out quickly using the suppression technique we're going to practice in a bit. So it's not always getting people moving, it's let's deal with it right here now. What's the A? Get the alarm activated. That is a fire. We need to treat it that way. If it's a live fire, we have to get people involved, we have to report that. We have to actually treat it that way and get people involved. C, closing doors, containing the space. You folks in the PACU, or pre or post operating space, it's big old open room, right? So we need to close doors. Do your patient bays have doors in between them? No. So we need to consider moving everybody all together when we talk about containing space, because we need to contain the smoke to where it starts. And then the E, evacuate. Some people say extinguish at this point, and that's good, but if we're able to take care of it right here, if we couldn't take care of it right here, then down here we're not going to take care of it. We're going to start getting people moving. And who makes that decision? How do we decide should we or should we not evacuate? Who's the person that makes that call? The fire department? There may not be here yet. All right, charge person, right? There's always a charge nurse. We need the charge person to make that call. All right. So if there is a fire, we need to get other folks involved. We're going to have the overhead page. You have overhead paging in the operating space. We want to let the charge nurse know what's going on, that we have a fire in the operating room. Talk about what we need immediately. The fire's put out, everything's all right, but we need to have additional saline brought in or whatever was used. We need additional drapes. We need to make sure the alarm gets activated. That's important. It is a fire. We have to treat it that way. We have to follow the RACE process. We need to activate the alarm. And again, I keep saying this, no matter how small the fire is or was, if we put it out, we need to get that, to communicate that outside of the operating suite to the control desk. All right, and then we decide we're gonna have to get out of there because the smoke's starting to fill the room up. Do we know where to go? We're going to talk about that when we do the tours in the building. Where are we moving folks? Where's our best location if we have to relocate? That's going to depend on where you are in the case. Do we need to reopen? Did we have to close up, or were we at a point where we were all set and just moving to the post care? The hallways. What are we doing in the hallways? Your hallways are always nice and clear, and there's nothing in them, right? No way. I walked in right here, and I know they're not even. I know you have stuff in your hallway, so we need to prepare for that. Get things. We need to get things moved out of the hallways there, and then is the evacuation site ready to receive you? We can't just show up and say, "Hey, we're here." We need to have that communication. Hey, we're going to go to room number 5. And get ready for us, we need this, that, and that. That's all the clinical stuff that you guys can talk about specifically for that case, but we need to have that communication, that open dialogue, like here we come, this is what we're going to need when we get there. There may be some things that you can have there already staged long before you get there. And then that the entire team is ready. We don't go until everyone goes. There's a decision that we're going to go, and the charge person is going to make that decision, but we're not going to go until everyone is set. All right, so there's constant communication there to make sure everybody's ready, and when everyone's ready, then we go. All right, so the circulator. Get the bag valve mask. Make sure we can get the air movement going. Get equipment out of the way. Make sure we know where we're going. Help move the table. Get things ready. Get things that are coming with us. And then make sure when we get out of the room, the door gets closed, right? You have markings, like a door that's fine. Make sure we know where the room of fire origin is. Make sure we know, not, once that door gets closed, we don't go back in there. We want to keep that door closed and keep that fire, keep that smoke in the room of origin. And the circulator should be ahead of the team. So make sure the door gets closed and kind of come around the table. Make sure we get in front of folks, clearing the hallway out to make sure we can get down the corridor quickly and safely. That's the circulator. Does that sound right? Is that what we've been practicing? I sure hope so, because that's what we certainly recommend doing. Scrub tech, can we close the patient? Is it at a point where we can do that? Do we need to? We're going to take any kind of instruments that we have on there, kind of wrap them up and get them moving. Assist in moving the OR table. Do we know how it breaks down? Do we know how it unplugs? The emergency brakes, all that kind of thing. We're going to practice that. Each table's a little bit different, so we want to make sure we put our hands on those. And then working together with the surgeon to make sure that things are set to go. Anesthesia provider, disconnect the equipment. We're going to shut off gases. Ventilate using room air. Any kind of drugs or anything we might need when we get to the evacuation site. And then ensure that the gases serving the space are shut off when we leave. So circulator, when we get out of the rooms, ensures that the door gets closed, but the anesthesia provider is going to give the okay that it's, yes, let's shut down the gases to that space. All right, this is highly critical. Once we're out of the room, if we can get to it safely, and if we're halfway down the hallway and we forgot to shut the gases off, are we going back? Don't worry about that. You're a fully sprinklered building. The fire will be contained in that space. Let's keep moving. There's other things we can do. We want to shut it down if we have it. We can get to it safely and quickly. But if we haven't done that, it's not totally critical at this point. Surgeon, we're going to stabilize the patient. Closing the site if you have time to do so. You're going to cover it and then communicate when to evacuate. The surgeon gives the go-ahead. We don't go until they're ready. They're going to set the pace. Kind of set. All right. Everything else is set. Patient's good to go. I'm ready. Let's go. All right. So that's the surgeon gives the call when we're ready to go. After we get out of the room, we're going to close it. We're going to shut off the gases. Mark the door if you're able to, or make sure that it's communicated which room we're coming from. We do not want to reopen that room of fire origin. Keep that door closed and mark it if possible. And then figure out where we're going to go and move that way. So you have an operating space here. Here's a floor plan, kind of updated from when we were here last time. So it kind of changes from, in our mind, kind of changed what the plan was. But if you're familiar with the space, here is OR 5 and 6, 7, 8, oriented correctly. All right, kind of the new space there. You see these dark red lines. These are your smoke barrier walls. Those are the walls we need to evacuate beyond. And when we talk about evacuating, we need to keep moving until we get to a protective barrier. These barriers are built with that in mind. We're able to defend in place for a significant amount of time within the building and not have to take people out into the parking lot. We don't want to do that. We want to care for them and treat them within the building as long as we possibly can. So as we start to say there's fires in this space here, we'll relocate into the, I believe that's the PACU space.
To the right.
I have it on my footprint. We want to get beyond the barrier walls, okay? Get to the other side of the barrier, get into a room that you can potentially reopen the case, get the patient stabilized, and treat them that way, or get them into wherever would be appropriate, taking the appropriate equipment. But that's why we want to walk your space. That's why we want you to understand where your barrier walls are, where that kind of line of demarcation is. How far do we have to go? We only want to have to move them once, so get them to the appropriate location the first time you move them. And then when the fire department arrives, if they give us the order that we're going to evacuate the building, we're not going to argue with them. We have to follow their call. But there's things we can do way ahead of them getting here. Because how long does it take for the fire department to get here? Where is the nearest station? I just drove 8 blocks away. Close, it sounds like, right? How long does it take them to get here? They're not waiting here at the parking lot waiting for something to happen, right? We have to do some things before they arrive, and this is kind of a chart we use to indicate why, you know, how long things typically take. So the fire takes a few minutes to actually get detected, maybe up to 90 seconds in some cases, whether the sprinkler head activates or the smoke alarm detects the fire. The fire alarm system has to kind of process that. There's a call that goes out to the central monitoring location. They answer the call, they verify it, are we sure there's a fire? They call the 911 dispatch, who then will dispatch the fire department. So the fire department will not get here until 4 to 5 minutes at the earliest. That's a long time. What happens to the fire in that time? If we have fire sprinklers, we might actually put the fire out long before the fire department gets here. But what's happening until that time? The fire's getting bigger and bigger and bigger, and we're having to deal with that. Smoke's starting to fill the rooms up, smoke's starting to potentially fill the hallways up. So we need to deal with that. That's why we need to make that decision and react so quickly, because when the fire department does get here at the 5-6 minute mark, we already have some things moving, and they're just going to pick up where we are. They're going to help us along with that process, kind of a shared command, unified command is the idea there. If we're taking care of things. If they arrive and we're kind of all in disarray, they're going to say, time out, that's it. You guys had your chance. We're taking over from there, and we lost our ability to kind of make clinical decisions on their behalf, all right? So it's important we understand that, we react quickly and get these things moving and get folks to where they need to be and keep them safe. All right, when evacuating, who instructs more than one OR to evacuate? Is it the fire response team, charge nurse, fire department? It's everybody. If we have to evacuate more than one OR, it's all hands on. The fire department can't make that call. They don't know what's going on in the operating room, all right? So there's going to be a lot of communication ahead of that. So if we have to evacuate more than one OR, and we're talking, the fire's potentially getting a little bit bigger, and we're having to deal with it, it's going to be communication that way. That's control station. That's where the nurse control station, the OR control station is so important, that all that information is coming into there so they can communicate it outside to the fire department, to the command post. All right, so there's a lot of talking. However that communication occurs, it's important that it is occurring. We're letting people know what's going on in those spaces. So what if you have to evacuate more than one OR? Well, we just said, it's all that decision making there. The charge nurse makes that call. Here's some immediate things that the person in charge is going to have to make sure it is occurring. So there's all kinds of moving parts, but these are the critical actions that must be taken to make sure that these things occur. The fire room has been evacuated. That's number one. Are we sure? Did we do a thorough search when we were leaving the room? Everyone came out. We got everybody out, and we closed the door, and no one's still back in that space. The doors to the fire room have been closed, and they're going to stay closed. Has the fire alarm been activated and a call placed to the operator to make sure that the communication is going out to the fire department to make sure they understand the fire is in the operating room, and it's more complex than just a typical fire that the fire department is going to respond to. Equipment's been removed from the hallways. That's that C of race: clear, closed, confined, clearing hallways out. Informing all the other ORs what's going on. Hey, this is what's going on. Prepare yourselves. We may have to continue this evacuation beyond room number one. It might include you guys, so it's that communication, and that's the overhead page. That's where that communication comes in. You obviously have ways to call into the operating spaces, whether it's with a page system, intercom system. And then designate a staff member to bring a phone list so we know we can communicate and all that information. If we happen to have to leave the control desk, we need to take some information with us. And this is just an example of one of the items to bring with us. There's probably some other things, whether it's tools, instruments, a variety of things that we might need, but it's case dependent. Who's being moved? At what point are they in the case at the time? And what are we going to need at the site if it's not already prepped for us? So why do we make the decision to evacuate quickly? This is why. We don't want to be moving people through a smoke-filled hallway. This is a smoke-filled hallway. This is a video, it's not a picture. You kind of see people popping in and out. This is a smoke-filled hallway. If we had this type of condition, are we going to evacuate our space? There's two rules when we talk about evacuation. It sounds like a pretty daunting decision. Should we make it, should we not? There's two simple rules. Is the fire still burning? And in the case of a piece of equipment or something like that, the fire's still burning when we shut the door, what can we assume? Fire's still burning, right? So the fire's still burning and there's little or no smoke in the corridor, we're going to evacuate. Let's get people moving. But if we have this type of situation, keep the door closed, stay in the room, because we don't want to be moving people through a smoke-filled hallway. Okay? So oftentimes, in a situation like this, it's far better for the patient, far better for the occupants to be in a room with the door closed, to keep that smoke and everything out in the corridor without us going in there. Those walls that you have, those corridor doors, are built in such a way they're going to protect you from that smoke for a significant amount of time, and we'll keep that smoke at bay if we keep that door closed. That's why it's so important we recognize what's going on. We act quickly to keep, if the fire were in a room, we can keep it in the room by keeping that door closed. Once we open that door up, all that smoke's coming out, and how long does that take for a hallway to fill with smoke when the door gets open? Well, we're going to find out. So here's a situation. This is an apartment building. We don't get many opportunities to get live video of fires happening in operating rooms or hospitals, so we take what we can get. This is a pretty good demonstration of how things happen. So if we're making the decision, should we evacuate, should we not? Here's a hallway, not a whole lot of smoke in there. Should we evacuate through there? I'd say it's safe to do so, yep. We have the opportunity, let's get people moving. How about now? The smoke's starting to kind of billow in there. Maybe if we're already started, we can continue. I'd say so. How about now? Would we evacuate through that corridor? I wouldn't. We'd have to stay low if we were doing that, but that smoke's starting to fill up. It's a pretty dangerous environment. We would not want to evacuate through that space. So how long does it take to get from one point to another with this situation? Well, let's time it. 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5. So about 5 seconds for that hallway to get to a point that it's not safe to evacuate through. So what happened when they opened that door up? All that smoke that was trapped in that space came pouring out, and we lost our chance to evacuate. So as we're talking response and responding to a fire, if someone shows up, the alarm's going off, people are showing up, hey, we're going to put this fire out, and the door to the room is closed, are we going to let them reopen that door and try and put the fire out? Maybe they brought their extinguisher from a mile away. No, keep that door closed, because what happens, that smoke is going to overwhelm them. Now you can't get the door closed because your door's open in, most likely. Now you can't get in the room to close the door. Now that smoke's just going to keep coming out, and we lost our chance to do some things that we could have done with that door closed. All right? Here's an example of a fire on one side of the corridor, or in the corridor on one side of the smoke barrier walls. The doors stayed closed. The entire space was charred and damaged. Everything's a whole big old mess there. This is the other side of that same corridor. Those smoke barrier walls are designed to keep that smoke, keep that fire at bay for a significant amount of time. Technically, it's an hour fire rating, but with fire sprinklers, a fully sprinklered building, it's going to withstand that for even longer than that. The minimum is an hour. All right? That's why we close those doors and we keep them closed, and we relocate our folks to those spaces. We use those barriers, we use those protection features to our advantage, because it'll protect us that way. All right. Any questions over the race process? No? Pretty straightforward, but this is why we talk about it. It's that quick decision making of, should we evacuate? Should we continue this evacuation? And it starts with the charge person making that call based on the fire conditions and the smoke conditions. Is the fire still burning? And is there smoke in the corridor? Those are the factors. All right, let's talk about prevention. Talk about the fire triangle. We talk about the ignition source. There's an oxidizer and a fuel. If we don't have one of those, we don't have fire. So it takes all three. And what do you have in the operating space? You have all three and then some. So let's figure out where we start here. So Fires are happening all across the country. We keep talking surgical fire, and it seems like the more we talk about them, the more we hear about them, because it's kind of been this unspoken thing for so long. So they're still happening out there, and it's causing some serious damage. So skid preps, a variety of different things causing these fires and significantly harming these patients. So we have to understand how we can prevent it from occurring. Joint Commission, CMS, have these requirements to make sure that we train you every year. It was not a requirement up until recently. It was a good idea, and you've done that. It's been great. You were ahead of the curve here. But CMS mandated it, and Joint Commission put it into their standards. Here's the specifics. Do we have an understanding for how to respond to fire alarms, how to report, when to report them, procedures on how to deal with flammable germicides. Make sure we have that in place. Do you use flammable anesthetics or preps? Yeah. Okay. So we'll talk about those when we get in that space. Yeah. Okay. So do we have an understanding for how to deal with that? And having some sort of procedures. You have those. You've had them for quite some time. That's great. But it is a federal requirement at this point because more and more fires were occurring, and people weren't getting the idea about maybe we shouldn't have these fires. So the federal folks had to step in, and we have to train new OR personnel and continuing education from then on. So how do we deal with that? How do we deal with that? You have your surgical timeout, and Barb gave you that. You have it right in the electronic record, right? That's done in every case. Every single case, we have some sort of surgical timeout to do a fire risk assessment. What do we have? And that's why we ask those questions. Is the surgical site above the xiphoid? Because that's where most of the fires are occurring. That's where the high problem area is. Do we have open oxygen delivery? And is there an available ignition source? So this is your surgical timeout. We're answering these questions, and then based on the answers, then we have to take some steps to mitigate that. So that's why we ask that, because it takes those three parts of the triangle to have a fire. If we can eliminate one of those legs, then we can prevent anything from occurring or have a lower likelihood of it occurring. This is an example. We have yours there. So based on the score, that's how we take it there. Excuse me. So the Preventing Surgical Fires Initiative was put together by the CSPS. It was to increase the awareness of factors that are contributing to these fires. That's where this timeout comes from. That's where the surgical fire risk assessment comes from. Having an understanding of what's going on in those spaces, and making sure that we're getting prevention tools out there. This seems to be working for you, so keep doing it. I wouldn't change it. If it's not broke, don't fix it. But there are other resources out there to help mitigate things as different procedures come out, or different prep solutions, or different technology comes out. How are we dealing with that in your space? There's other resources out there for you. Let's talk about a case study. So this is where we'll get into some of the clinical stuff, so work with me here. I'm going to take some liberties in the actual cases that were going on, but we can get the idea here of what was going on. So two phases of the case. The first part was the removal of a lesion on the shoulder, and then the second part was removal of a mole on the neck. Okay, so it's all above the xiphoid process. Nasal cannula was at 100%. I heard that. That's a lot, right? The patient was draped, prepped, and the shoulder procedure completed, no issues. Everything went fine. So they they moved over to the mole removal on the neck. All of a sudden, fire. Boom, just like that. Popped open. Blue flash. There was a sponge stuck underneath the shoulder, so when they rolled, it exposed that. There was some pooling underneath, and when they went to remove the mole there, it ignited. So everything was going fine at first. You can't just kind of forget. You kind of, almost in this case, they should have had almost a secondary timeout when you went from one phase to the next. So that's the idea there. Once everything was going fine, they said, oh, everything's fine, and then they moved over, and they didn't do the next steps of getting the fire prevented there. They didn't do that secondary step. All right. So, how do these fires happen? It's these three pieces here. Where's the gas come in? The open delivery of oxygen. I heard the phew, when they were talking that 100% cannula. Can we reduce that? Is there a way to do that? I'm not, like I keep saying, I'm not a clinical guy from that aspect. I don't know what the limitations are there, but can we reduce it? Can we have it in a mask? Does it have to be other additional air being blown by so we can kind of dilute the space? Kind of leave that up to you depending on what the case would call for. But we want to have a limited oxygen environment, or reducing the amount of oxygen that's kept in that space. So getting rid of the open delivery, if we can put some blow-by air there. And then 65% of these fires that are occurring occur above that xiphoid, and that's why it's so critical that we identify that within the risk assessment there. So if we can keep it, if we can't, I mean, it's going to be a clinical decision, but if you have to have that open delivery, you want to take account for that some other way. And maybe that's with a tube or some sort of mask. So, what is the risk when we talk about oxygen? What happens in an oxygen-enriched atmosphere? Is oxygen if you feel we need to. Eye protection, for not only for the people using it, but obviously, but also for the patient themselves. They need to be protected because they're not really aware of what's going on in that space. And then, of course, they should be available to all that might be entering into the room for whatever reason. All right, so putting out airway fires. Can they occur? Yes. Hopefully they don't, because we've taken all these steps. We did our surgical timeouts. We made sure that we have all these processes in place. But if something were to happen, how do we deal with that? How do we put out an ET tube fire? How do we deal with something like that? If the ET tube's down in the airway and the camera's getting fogged up, something's going on in there, you start to smell something or start to see something, how do we deal with that? We want to quickly take care of that. So we'll talk about each of these, how to put out these types of fires here. The airway, the ET tube can actually act as a blowtorch when the oxygen's coming in there, because the oxygen can enrich the plastic itself, and it can actually act as a blowtorch, kind of melting down and reacting quickly that way. Is there fire on the drapes potentially? Maybe the cautery got set down on the drapes, it gets ignited. How do we deal with that? And that's what we're going to practice here in a few minutes. And then maybe a piece of equipment gets ignited. How do we deal with that? Well, we have fire extinguishers in the area, right? That's what we can use that for. So we'll talk through each of those in detail there. What's the first thing we yell out when we think we see a fire? Normally, we're going to yell code red, right? If we're out in the hospital, if we're out in the patient unit, we're going to yell out code red and get these things moving. Okay, that's important. We know how to respond to that. Kind of have that visceral reaction. All right, I code red. I know I need to do some things. All right. But if we're in the operating space and we think there's a fire either on or near the patient, what are we yelling out? Fire! Shut off the gases. Nice and loud. Nice and loud. Make sure everyone's aware, because within that operating space, you need to react quickly. We need to get those gases shut off to prevent anything further from occurring within the patient, okay? So outside of the operating suite, we're talking code red. That's our code word. We get everyone involved. It's a team effort. But in the operating space, we need to be yelling, fire, shut off the gases. Kind of that automatic reaction. Get those gases shut off immediately and quickly. You shut it off. Each one's a little different on how we get the gases shut off immediately to the patient there. We're going to shut off the gases, get the tube out of the airway, and then treat the patient. We want to make sure we shut the gases off first, because you saw that ET tube kind of looks like a blowtorch. If we don't shut the gases off and we pull that ET tube out, what's going on as it's on its way out? It's charring everything on its way out. So we need to shut the gases off before we remove the tube. All right. And then we're going to take care of the patient as needed, whether it's whatever the case may be. Get that patient breathing again if that's occurring, or do all your clinical things to take care of that patient. And then reestablish the airway if it's ready to do so. I have another clip here about what that looks like.
One of the most dangerous surgical fires are ET tube fires.
ET tube, you can see, this is a dummy, by the way. It's not a real person. But you can see the smoke coming out because of the fire in the ET tube. So he shut the gases off, got the tube out of there, or got the interior tube there, and then pulls the second tube out and extinguishes it with saline, puts it in a bucket, in a dish there. All right? So it can happen that quickly. You kind of saw at the start there, smoke was kind of coming out. You immediately know something's going on. Whoever sees that yells out, fire, shut off the gases. You need to immediately get those gases shut off, because it can happen just that quickly. Now that type of situation, are we yelling out code red or anything like that? Well, outside of the space, we need to alert somebody that this is going on, that is a fire. We need to treat it that way. We need to alert the control desk, the OR control desk, get the alarm activated, and get people aware that something's going on while they're taking care of that patient, okay? So yes, we do need to get that activated. Even for a situation where we are fairly confident that that fire is put out, we still need to get other folks involved, because it's going to take some other things there. Okay. Can we pour saline down in there? If if there's a fire in the surgical site, so maybe not down in the airway, but on the surgical site itself, can we pour saline in quickly? We have it in the basin next to us. Replace the tube, get rid of the extinguished materials, get the drapes off. We need to look for any additional flame. If we're in the surgical and there's a fire in there and we think we put it out, we need to be sure. We need to get the drapes off of there and look underneath the thing to make sure nothing was pooling underneath. When we get into the operating room, we're gonna, this flame can kind of disappear on us under those bright lights. We need to ensure that we got everything taken care of and we've identified that all the fire is out by removing the drapes, getting it off of there, and doing an additional search for fire. And of course, treat the patient, treat the burns, treat the issue that may. So nothing's perfect, but if we do happen to get a fire on the surgical site, this is how we can take care of it. Get the saline in there, something we have nearby, and treat the patient that way. Extinguisher on a surgical site fire? Not if we don't have to. Right? We want to use what we have available to us and treat it that way. We don't necessarily want to grab one of those. How about drapes? Drape fires can occur, so if we're not talking on or in the patient, we're talking on the drapes. Get the material to the floor. Get it off the patient if it's possible to do so. If it's not possible, want to get saline down on there or use our towel method, the clothing fire or surgical drape fire suppression technique. All right, we're going to practice that here shortly. Kind of sweep the fire out to make sure we get it out. If we can't do that, get the material to the floor and then potentially grab the extinguisher and put the fire out. If it's off the patient, off to the side, use the extinguisher and we can deal with it that way. But we are yet still shouting out, fire, shut off the gases. We don't want those gases to be pooling in and around the drapes to help the drapes ignite, because although they are fire resistant, again, if it's an oxygen enriched environment, it will sustain combustion. All right, so we're going to do a live fire demonstration now, and before everybody jumps up at once, please consider opting out if you have any of those conditions there. So what I'm going to do is I'm going to demonstrate it first. I'll show everyone what I'm describing, and then I'll give you an opportunity to go over and do it yourself. Put hands on this stuff, okay? All right. So, type of thing. We're on the bed here. What do we have nearby we can use to put out a fire that might be occurring? You have towels, these types. You probably don't have these types, but maybe you do. Have a towel, have a sheet, have a surgical drape, anything like that. That can handle. What we want to do, we want to take the sheet, take the drape, whatever we have available to us, take it out in front of us like this, shoulder width apart, maybe a little further. And with one arm, we're going to protect the airway. So if the patient, who's ahead? This one?
You're right.
Yeah. Okay. If the patient was lying this way, the head's up here, I want to protect their airway. So I'm going to take this sheet, kind of wrap it up under my arm like this, and put it right over their chest, protect their airway. We don't want any heat or smoke going towards them. Next, I take the other side of the drape and drape it over like that. And I do a sweeping motion to put the fire out. I want to separate the oxygen from the fire. All right, I want to try and smother it out like this. I don't want to pad it, because what can happen when I pad it is just bringing air up and in, right? So I want to sweep. I want to do a sweeping motion, all the while keeping my arm here, protecting the patient's airway. Once I think it's out, I can grab the sheet like this, take a look and see if it's out. If it's not out, I just repeat. Okay, so if we don't have saline or anything like that nearby, we can use these drapes, we can use the sheet, whatever we have in the operating space. So who wants to give it a shot? Got it. Now, grab the sheet. For this case, for the purpose of the drill, because we're gonna have to evacuate, this situation, we're getting smoke in from the ventilation system.
Okay.
We don't know where it necessarily is coming from, but we get out of here relatively quickly, all right?
Okay.
So when we get the,
Yeah.
oh, all right, so we're working on the case, and smoke starts to kind of fill the room up. What are we doing?
There's smoke in here, we gotta get out.
Yep, so I call the desk.
Yes.
Say fire, no R4.
Yes.
So let's do that.
Yes.
Okay.
If you close the patient, do it. If you can't, I cover it.
Right.
Hey, we're moving. Do I keep instruments on here?
Okay.
On my desk?
Yeah, so however you
Because we have to
hold on.
close that
Exactly.
patient out that
Like
way.
that.
Okay, go ahead. No, not the front desk. We have fire, no R4.
So we relocated to the PACU now. Now that we get into this space, now we can decide if we need to reopen and maybe continue potentially, or get to a safe. We didn't close. So
But
then
the
we'll-
problem-
so then we'll close then.
You guys, what's the problem though in this room?
We're not away from the.
We are not out of the same containment as
Okay,
OR4.
so we should have
We need
gone-
to go evacuate either to 5 or 6 or into PPD. Because
Okay, so
this
we
is
can-
we're
encompassed
in
to
the
a 3, or
same
same fire
We
compartment.
need to go to PPD.
We need to go.
We should
to the
evacuate to
wall.
PPD or get to 5 and 6. Like if we need to continue a surgery on this patient, maybe head to 5 or 6 if it was open.
Right.
Okay, because that
Safe
wall
barrier.
encompasses here, so everything this way minus PPD
So
and the
we,
new rooms, so.
we would continue to.
You could have
because-
continued.
Well, being that it's a normal OR day, we just continue on
To, yeah,
to PPD.
yeah, I'm just,
Yeah.
so everybody knows, this and the room 3, 4, 1, and 2
Yeah.
are all in one unit.
Yep.
7, 8, 5, 6, and PPD are all in the other unit,
Okay.
so, okay.
Okay.
That's a pretty important note.
Yeah.
Um,
Yeah,
really,
well,
that is pretty
yeah,
important.
I'm just, we should have,
And I would have had to call,
Everybody.
well, like to see where it goes.
yeah, right.
Or what room's
What
open.
room's open, right.
What
We would have had a
room's
lot
open,
more
yeah.
conversation as we're going,
Yeah,
where are we
right.
going, how are we
Yeah.
getting there?
Attention, attention, fire alarm activation drill, all clear. Attention, attention, fire alarm activation drill, all clear.
If you look close at the package. Flammable all over it, but it says right here. Right here, 3-minute dry time on hairless skin, up to 1 hour in
Up to
here.
1 hour, yep,
1 hour.
yep.
That's,
And we practice
you're not
that,
doing
and we
that.
shave our patients completely because of that.
Right.
It real, the pooling, you know, we don't want it to pool, so
Right.
that's where,
And saturated. There you go. There it goes.
see, yeah. It's there it is. Take the light, yeah, see how you can't see it, but then when you take the light away, you can see.
Yeah, so you're gonna smell it.
Mm-hmm,
That's how you're gonna identify that something's going on.
mm-hmm, but take that light away again for a minute.
Okay.
See how, yeah,
Nice and,
there you go.
nice and bright.
You just see the tip of it, but the,
Right. Yeah, so, and I had to get all kinds in there, so it's up and under and in the pad now, so, you know, this technique, you have to just smother it out completely. If it were the site, you wanna make sure you get it, smother it out, get it all out of there.
yeah, still smoking.
Make sure it's out. And then obviously if this were the drapes, we want to, after we think it's out, get it to the floor, get it away, and then deal with the patient.